Lecture αυτού του συνεδρίου θα γίνει από την Dr. Shaw. Γυρίζω στα αγγλικά. We are very happy and privileged to have with us Dr. Jacqueline Shaw, who is an expert on the topic that she is going to present in spontaneous coronary artery dissection, a clinical situation where in many occasions we do not know exactly what to do, and we are very happy to share with you some discussions later. So, Jackie.
Great. Thank you very much, Apostolos. Can you hear me okay?
Yes, very well.
Wonderful. Great. Thank you so much for having me and to present on an update on SCAD. And I'll try and make it, you said 25 minutes, right? Okay. All right. So SCAD is defined as a spontaneous tear of the coronary artery wall, and this results in an intramural hematoma in the false lumen. And this can happen from an actual intimal tear or from spontaneous bleeding from vasa vasorum. And you see later that the key pathophysiology is actually the intramural hematoma. So SCAD results in a type 2 MI, and it's a non-atherosclerotic cause, and is basically one of the most important causes, and I will show you the data behind that. So when we look at publications for SCAD, this is, I just got this diagram from PubMed yesterday. You can see that, since 2012, there is a whole increase in the number of publications since then. Just last year alone, 216 publications, and this year so far, 65 publications. And really, our ability to pick up SCAD was really because of intracoronary imaging, because angiography was missing SCAD for many decades. So this is the first paper that was published on SCAD seen on IVUS. This is published by Akiko back 2002. Of the 15,000 IVUS that they looked at, only 5 had spontaneous coronary dissection, and these were all cases with intramural hematoma, and none of these 5 patients had intimal tear. Now, it is hard to pick up SCAD on IVUS, so the key change is actually OCT imaging back in 2011. This is the first case report in April 2011 that showed clear visualization of the intramural hematoma on OCT compared to IVUS. So this first case report, I remember, was published online, and we at Vancouver General Hospital just acquired OCT imaging at the same time. So literally in April 2011, I saw these 3 cases in a 2-week period. And all these 3 young women presented with either a STEMI or a non-STEMI. And these are the angiograms that I've shown here. On the left panel, 35-year-old female with long diffuse narrowing in the right coronary. The mid panel, 48-year-old female with a tubular stenosis in the mid-LAD. And the right panel, 45-year-old female with, again, tubular stenosis. And all these 3 angiographic appearances is not typical of SCAD. So all these 3 cases, we did OCT, and all showed intramural hematoma. So I saw 3 cases in 2 weeks, and clearly this highlights that angiography is poor in picking up SCAD. As well, this was around the time where we were interested in looking at fibromuscular dysplasia. So we screened all our patients for FMD, and all three of these patients actually had concomitant FMD in the renals or iliacs. So I published the first 6 cases because I submitted the first 3 cases, and then through revision, we saw 3 more patients. So the first 6 cases were published here in this paper of both SCAD and FMD, showing the link. So it's very clear from these early experience that we don't really know how to diagnose SCAD on angiogram. We don't even know how common it is, and it's obviously not rare. And the problem with coronary angiogram, even though it is the gold standard, it's just that we don't image the arterial wall. So when you have a long diffuse narrowing like this example here, it can often be read as natural tapering. So the key pathophysiology is intramural hematoma. If you do OCT or IVUS, you typically would see intramural hematoma. You may or may not see intimal disruption of intimal tear, but you will clearly see intramural hematoma. And sometimes these can be subtle, like this example here where we had to do intracoronary imaging. So when I first got interested in SCAD, I pulled up all young women less than age 50 who had angiogram at my hospital. And so of these angiograms, we found that a quarter of them actually was SCAD that caused the MI. So these were all missed SCAD cases. And so we decided to do a prospective study. So this was a 2-hospital study at VGH and St. Paul's, where we enrolled young women less than age 55 who presented with an MI, and we looked at what are the causes of these MIs, and SCAD was the cause in 33% of these cases. And when you look at non-atherosclerotic causes of disease, so NACAT, SCAD accounted for 73%, 72.6%. So SCAD is a very common non-atherosclerotic causes of CAD. So it became very obvious very early on that we needed to have a new angiographic classification of SCAD because we were not describing these long diffuse narrowing. So I actually published on the classification for SCAD back in 2014. That was the first paper. And so over the ensuing year or two, we had to do a lot of intracoronary imaging to prove to people that these long diffuse narrowing and these tubular narrowings were indeed SCAD. So we correlated that to intracoronary imaging. So this is the official angiographic classification of SCAD. So type 1 is when you have multiple radiolucent lumen, which is the textbook form of SCAD on angiogram. Type 2 is when you have long diffuse narrowing. So type 2A is when you have a normal vessel before and after this long diffuse narrowing, so it's easier to pick it up. Type 2B is when you have long diffuse narrowing that extends all the way to the apical tip of the vessel that may be missed because people might interpret as a normal tapering, so you have to be careful about the type 2B. And then type 3 are the shorter lesions, so these are what we call focal tubular lesions that appears and mimics atherosclerosis, and these are the cases where you typically need intracoronary imaging. So that's the official SCAD classification. So some of the Europeans like to use an additional type 4 classification, and we don't actually use it because type 4 is meant to include total occlusion of a distal vessel. We find that in our core lab, if you have a total occlusion that you're unsure that it's SCAD, you shouldn't even label it as SCAD. But in cases of SCAD, where the vessel is occluded, if there's long diffuse narrowing before the occlusion, we actually call it type 2B. So that would be a type 2B SCAD. And in our Canadian SCAD registry, 30% of vessels were occluded. So we don't want to label all these 30% as type 4. So this is a SCAD diagnostic algorithm. Basically, if you have a patient, especially a young woman with no other cardiovascular risk factors, that you're worried about SCAD, then this is what we recommend. You start with a coronary angiography. If you see a type 1 appearance, then the SCAD diagnosis is made. If not, you look for the long diffuse narrowing, which is a type 2. And if you see that, you want to make sure you give nitroglycerin to make sure this is not spasm. And so if you're uncertain, you can repeat angiogram in 4 to 6 weeks, or you can do OCT IVUS. If you have type 3 changes, meaning that they look like atherosclerosis, but you're concerned about SCAD, and those are the cases, then we would recommend doing OCT or IVUS. So when we look at a Canadian SCAD registry, which is, we enrolled 750 patients throughout North America in 22 centers. These are prospectively enrolled patients. These, we have 1,000 dissected arteries, and all these arteries were reviewed in our core lab by John Mancini's lab. So you look at the angiographic appearance, the most common appearance is type 2 in 60% of cases. Type 3 is only in 11% of cases. And then type 1, the multiple radiolucent lumen, is only in 29%. In this series, we had to do intracoronary imaging in 8% of cases. Important to note that SCAD can affect any artery, but the most commonly involved vessel is the LAD. But you can get left main involvement in 1.5%. You can get multi-vessel, non-contiguous SCAD in 13% of cases. And about 8% of cases, the SCAD affects the large vessel. So these will be like the proximal LAD, prox cert, prox right, or the left main. But majority of SCAD affects mid to distal vessels. And very importantly, usually there is wall motion abnormality that's subtended by the SCAD artery. So this can help you look for the SCAD vessel if it's subtle. So intracoronary imaging has been important to help us improve our ability to pick up SCAD, but it's not necessarily safe to do in all cases. So OCT had been preferred for a while because it has much better resolution, but nowadays with the high-def IVUS, with resolution down to 40 microns, is actually our preferred imaging modality if we're uncertain on angiography. So we looked at how safe it is to do intracoronary imaging. So of the 1,300 additional CAN-SCAD cohort that we have now, only 5.3% had intracoronary imaging, and it's actually not necessarily safe. So the complication rate was 8.6% of these SCAD patients, which is a lot higher than general population where you're doing intracoronary imaging, where the complication is only 0.5 or 0.6%. So this is more than 10-fold higher of complication when you're doing intracoronary imaging in SCAD patients. And these complications include iatrogenic catheter-induced dissection, propagation of dissection of the wiring, further ST elevation, and even with OCT, you get hydraulic extension when you're injecting contrast to visualize this. So this is not rare. So I think you've got to be careful. So the recommendation for intracoronary imaging for SCAD nowadays only perform when the diagnosis is uncertain, and that's typically only the type 3 cases. And you need to have meticulous techniques by experienced operators, make sure your guide is coaxial, and only image short segments. You don't need to give vast volume or contrast. And generally, we prefer the high-def IVUS versus OCT. Now, even just doing coronary angiogram may not be safe in this population of patients. So we look at this a while back now, published in 2016, where we look at the risk of catheter-induced iatrogenic dissection in patients with SCAD. The overall incidence of iatrogenic catheter dissection is 3.4%. This is about 20-fold higher than the general population undergoing coronary angiography. So this is obviously a at-risk population. The arteries are frail. There's more risk for iatrogenic tears of the arteries by the guide catheters. So the risk of iatrogenic dissections are using guide catheters, deep intubation, and radial approach versus femoral approach. So these are important things to keep in mind when you're doing angiography. And in the updated Canadian SCAD registry, we still have iatrogenic tear of 1.9%. So this still represents at least 15-fold higher incidence than general population. So then there's a lot of question, can we use non-invasive imaging like CT to image SCAD? And these are some of the features that you can see for patients with SCAD on CT, and that may be long narrowing, intramural hematoma, luminal occlusion, you can have pericardial fat stranding, you may see dissection flat, but these are actually very rare to see. It's actually very hard to pick up SCAD on cardiac CT. As I mentioned, in 80 to 90% of cases, SCAD affects mid to distal vessels where the resolution of cardiac CT is not very good. So these are two case series that looked at cardiac CT to pick up SCAD. The first series on the left, 18 lesions in 11 patients. Cardiac CT only picked up 78%. And on the right, 16 vessels and 14 patients with SCAD. And cardiac CT only picked up 2 cases. So the sensitivity can be quite poor with cardiac CTA. So currently it's still not the gold standard to pick up SCAD. So we still need catheter angiography. So what about the causes of SCAD? This has plagued us for many years. We know that most SCAD affects women in about 90% of cases. And so the mean age is not really the young women, it's actually young to middle-aged women. So the mean age is 51.8 years in the Canadian SCAD study. And of these women, 55% were postmenopausal. So if you look at the age range, it's between 24 to 89. And about 9% of patients with SCAD were older than age 65. So just because of postmenopausal women comes in, I don't exclude SCAD as a potential cause. So it's not limited to just young women. And when you look at some of the risk factors, a lot of them have other concomitant issues like migraines or depression and anxiety. It's a very common feature of patients with SCAD. So how SCAD patients present, in almost all cases, they present acutely with an MI, either with a non-STEMI in 70% of cases or a STEMI in about 30% of cases. And chest pain is still the most predominant presenting symptoms in 91% of cases. And I've not seen an acute SCAD with troponin that's not elevated. It's either is that or they've just been missed or delayed presentation. A proportion can present with VF, VT, 8% of cases, and about a quarter of patients have wall motion LV dysfunction. So that's important to note. So the causes of SCAD, basically, the arteries are weak. There's usually a predisposing arteriopathy that weakens the arterial wall, and there's usually an additional cardiocirculatory stress that then provokes a tear in the perfect storm scenario. So some of these predisposing causes, I already mentioned fibromuscular dysplasia earlier. This is a very important link. But the other causes include multiple pregnancies, postpartum, underlying connective tissue disorders like Marfan's, Loeys-Dietz, Ehlers-Danlos syndrome, and perhaps linked with systemic inflammatory disease like Crohn's or lupus, and use of hormonal therapy, especially fertility treatment. So these are potential predisposing causes. And then precipitating stresses are things like intense exercises, intense emotional stress, labor and delivery. These can provoke SCAD when patients have frail arteries to begin with. So I'll spend a couple of minutes on FMD. So FMD is an idiopathic, non-atherosclerotic, non-inflammatory disease of arterial walls, predominantly affecting small to medium-sized arteries. And the classic appearance is the string of beads appearance that we see usually in renal artery, iliacs, and even the cerebrovasculature. But what is important is that FMD can weaken the arterial wall and cause dissection, okay? And so there are actual pathology, histopathology reports of patients who died from SCAD and found to have FMD adjacent to the segment of SCAD. So FMD can clearly cause SCAD. It's just that these cases are the rare ones, whereas most patients actually survive these SCAD events. So the link between FMD and SCAD have been explored. Probably it's not just being exposed to hormone therapy, which is also a common risk factor for FMD. There are some genetic risk, including the factor 1 gene, where the A allele can increase the risk of SCAD by about 67% and increase the risk of FMD by 39%. So there are probably some additional genetic linkage that has not been reported yet. So when we first got interested in SCAD and FMD, we screened FMD in all SCAD patients using catheter angiography, and we picked up FMD in 86% of SCAD patients, and this is very high. But once we kind of educate our colleagues about FMD, people start doing more CT angiography, which is really what's advised by the FMD gurus, instead of doing catheter angiography. It's just that the pickup rate on CT is a lot lower. So when I do a peripheral intervention and screen for FMD, I do it under DSA. So I do a pigtail injection in the renals, and then I do a pigtail injection for lower abdomen to look at the iliacs, right? And you can pick that up a lot better. So when you compare CT versus catheter angiography to pick up FMD in SCAD patients, the sensitivity of CT is only 22%. So that's why, where a lot of cases of FMD are being missed if you just use CT. And if you use MR angiography, the sensitivity is even worse. So I would not advise that. So when we look at the CAN-SCAD study, in terms of people screening for FMD, so we recommend screening for FMD in the head, renal, and iliacs. So for those who are screened, and these are mostly screened by CT now, we are picking up FMD in 56% of cases. So this is the most dominant risk factor compared to all the other ones that I've mentioned. If you look at systemic inflammatory disease, less than 4%. Connective tissue disorder, less than 3%. Hormone therapy use 10%. Peripartum was less than 5%. Okay, so that's important to note. It's not as dominant as what we used to think. And so in terms of pregnancy-related SCAD, not just the postpartum ones where the patients can have worse outcomes, but patients with multiple pregnancies. So you've seen patients with like more than 5 pregnancies or 6 pregnancies, they are at risk for SCAD because of the recurrent exposure to hormones during the pregnancy, that these cumulative effects can weaken the coronary arterial wall. I won't go into the genetics, but there's a lot of work being done recently to look at genetic predisposition and new genes. And this is a collaboration, meta-analysis of GWAS that was done of 2,000 SCAD cases with 9,000 controls. And we identified 16 risk loci, demonstrating basically polygenic inheritance for this disease. Now, what about precipitating stressors? Emotional stressor and physical stress are very common. We actually have all our SCAD registry patients fill out a questionnaire to tell us if they have emotional stress and how severe it was within the week before the event. Likewise for physical stress. And so emotional stress in 50% of cases and physical stress in about 30% of cases. Importantly, there's a difference between men and women when they present with SCAD. So number one, men is a lot less likely to have SCAD, right? 10% of our cohort of SCAD is men. And but men with SCAD have a much likelihood of having physical stress as a trigger and less likely to have emotional stress as a trigger. And also men are less likely to have FMD compared to women. So about 28% versus 53% for women with FMD. But men is very rare to have FMD to begin with. So men accounts for 1 in 10 cases of FMD as well. So the fact that it's 30% here in SCAD patients also basically highlights the link between FMD and SCAD. Importantly, the outcomes between men and women are mostly not different except for readmission with chest pain, which is higher with men. So this is something to note. So how do we treat patients with SCAD? We've learned very early on that most SCAD arteries, if the patients are stable and you leave them and you treat them conservatively, these arteries heal. So in our series here, 202 patients had repeat angiogram. We excluded patients with PCI. Of those with 156 conservatively managed, and we repeated the angiogram. And when we look at angiograms done more than 30 days later, 95% have healed spontaneously. This is in line with other publications of smaller number of patients. So it's clear, if the patient is stable, you do not want to intervene because they will heal spontaneously. And so when we manage these patients, very fortunately, most SCAD patients, by the time they present to the cath lab, they've had no further chest pain, they've settled down. So according to the AHA scientific statement and the ESC statement, we would manage these patients conservatively, meaning we monitor them in hospital 3 to 5 days, we put them on aspirin and beta blocker. But if the patient has any high-risk features, and so this basically include patients with left main dissection, cardiogenic shock, or ventricular arrhythmias, or ongoing ischemia of ST elevation, these are the ones we need to consider PCI. And if they fail PCI or they have left main, then we will consider bypass surgery. So this is the 2021 ACC-AHA SCAI guidelines for coronary revascularization. It's class 2B for SCAD patients who have hemodynamic instability or ongoing ischemia despite conservative management. But it's a class 3 for routine revascularization. So we should not perform routine revascularization for SCAD patients. This is our current practice. So in the Canadian SCAD study of the 750 patients enrolled prospectively, 86% were treated upfront conservatively. And subsequently, these cohort, 2.3% required revascularization. So most patients actually did well with conservative management. So in total, 84% treated conservatively, only 14% required PCI. And when we look at PCI outcomes, they're not that good compared to general population, right? So of these 14% who had PCI, success rate and partial success was 70%. So 30% was outright unsuccessful. And if you look at the approaches that were done, it could be balloon only, cutting balloons, but stent in that era was most commonly done in 65% of cases. Importantly, when you look at outcomes with PCI after SCAD, obviously those patients who underwent PCI, they are a higher risk cohort of patients, right? So the in the hospital events are going to be higher, which is not surprising. But after they survive a hospitalization and then you follow them long-term, the long-term outcomes out to 3 years are actually not different between those who needed PCI versus those who did not have PCI. So this is reassuring in that if you have to intervene, you go ahead. And this is data from the Spanish registry. When they looked at patients with SCAD who underwent primary PCI, and they matched them and compared them to non-SCAD patients who had primary PCI, the in-hospital mortality and the 30-day readmission was not different. So this is, again, reassuring. If you have a patient with ongoing STEMI with SCAD and you need to intervene, you go ahead and intervene. And also, if you have a left main patient, this is a new paper that's just in press. So they look at 132 patients with left main SCAD in the literature. And most of these studies were including 1 or 2 patients, right? A lot of these patients, 36% had pregnancy-associated SCAD, so very different cohort of patients. But these patients with left main SCAD, they have more likelihood to require mechanical circulatory support, 33% versus 17%. And very importantly, if you do not revascularize these patients, their outcomes are worse. So when they compared invasive management with revascularization versus conservative management with left main SCAD, the hazard ratio is 0.37 if you were to revascularize these patients. And the outcomes we're talking about is mortality, need for LVAD, recurrent MI, and urgent revascularization. So it's important. Most left main patients needed to be treated invasively. So the challenges, though, with PCI with SCAD are multiple. And one of the most important one is iatrogenic catheter-induced dissection. I've seen this so many times. If that happens with left main dissection in this patient with SCAD, say in the OM, then they need to undergo bypass surgery. So it's really quite critical to try to avoid iatrogenic catheter-induced dissection. The other challenges with SCAD PCI are just squeezing the intramural hematoma either proximally or distally. And then you need long stents, and then you can have stent malposition after absorption of the intramural hematoma as well. So that's why SCAD PCI is so challenging. So I wrote this algorithm back a few years ago now to kind of give you guidance. If you have left main SCAD, most patients need cabbage. If you have non-left main SCAD, you want to see if you can wire into the true lumen. If you can't wire into the true lumen, you should probably stop. But if you can, then what you do really depends on the length of the lesion. And if you have a short lesion like type 3, you can cover with a long stent. You want to cover edges by at least 5 millimeters both sides, and then that's the way to go. But if you have a long diffuse narrowing with a lot of hematoma, nowadays, instead of putting long stents, I would just advise doing cutting balloons if it's feasible. So I'll show you a couple of examples. So this is a patient with type 1 SCAD and mid-LED. We were able to wire down the true lumen, and then we were able to cover with a long stent by at least 5 millimeters on both edges, and we get decent results there. And this is an old case where I did with Simon Walsh when he was a fellow with me, where long diffuse type 2A of the mid to apical LED, we stented distal LED first, and then stented the proximal LED segment, and then stented the middle part. And the results were good, but then we ended up putting over 80 millimeters of stent in this case. So what we would do different now is to use cutting balloons instead. So this is a patient with a diagonal dissection with ongoing lateral ST elevation and chest pain. So I wired down the diagonal, and I'd use a 2O cutting balloon, and I'd fenestrate multiple inflations, and this is what the big diagonal looks like. We achieved basically TME3 flow. It's a very tortuous diagonal, so I don't want to put stents in. Her pain resolved, her STs resolved, so we actually didn't have to put a stent in this patient. So that will be the most common approach nowadays, is using cutting balloon. Now, in terms of bypass surgery, this is really a bailout setting for most of these patients, unless they have left main extensive dissection to begin with. Most of these cases would be patients who have failed PCI. In our Canadian SCAD study, only 0.7% required bypass surgery. An important thing about bypass surgery is that it really is to achieve survival for these patients, and you want to improve coronary perfusion acutely. So we tend to recommend using vein grafts as opposed to using internal memory grafts. And you want to do this really quickly to get survival. It's not about long-term patency of these grafts, because when the SCAD artery heals, the grafts usually go down with time. So it's really more for acute survival. And in terms of acute management, I'll wrap up really quickly. If you're suspicious of SCAD, generally, we want to do early invasive angiography rather than thrombolysis, for instance. So avoid thrombolysis if you can. And all the other medical management like heparin are usually administered before the patients come to the cath lab. But once we diagnose SCAD, I would stop the heparin. And then other agents are aspirin and beta blockers, which are standard long-term. When one of our retrospective series, we showed that use of beta blocker reduces the risk of recurrent SCAD. And then the other agents are all controversial. So clopidogrel is controversial. ACE inhibitor we use only patients that have LV dysfunction. Statins only if they have dyslipidemia. So this is the BA SCAD study. They just finished enrolling 600 patients. It's a 2x2 factorial design between beta blocker versus not, and SAP versus DAPT. So we hope to see results over the next couple of years. But this is a small study, 600 patients, so they have soft endpoints. But we actually are planning a global study called the APT SCAD study amongst 10 countries, led by the German group. And this is going to enroll 3,500 patients, randomizing them into basically DAPT versus SAP. So this will be launched later this year, and this will really address the issues about should we use DAPT. And the other strategies we recommend to prevent recurrent SCAD on top of beta blockers and management of hypertension is to try and really reduce emotional stress and reduce physical stress. Don't lift very heavy weights. Don't bear down. Avoid competitive sports. And also avoid future pregnancy. Those are generally what we recommend, and also avoiding hormonal therapy. And I'm just going to finish with the long-term outcomes. So when we look at SCAD out to 3 years, the risk of recurrent SCAD is only 2.4% with the strategies that we recommended, right? So using beta blockers and aspirin, reducing emotional stress, etc. So if you look at the 3-year utilization of beta blocker was 73% and aspirin was 80%. So it's important to note that I think these makes a difference in terms of reducing the recurrent events. And also to highlight that if you have FMD and your underlying genetic disorders like Marfan's, etc., and you have peripartum SCAD, your risk of MACE at 3 years is higher. So this is important to know that these are higher risk cohort patients. And a very common symptom post-SCAD is recurrent chest pain. And I just want to highlight at 3 years, still 1/3 of patients have recurrent chest pain. And so this is very common. And there is a nice algorithm in the AHA scientific statement that tells us how to investigate. The good news is that most of these recurrent chest pains post-SCAD are not due to extension of SCAD or recurrent SCAD or recurrent ACS. Most of these are atypical chest pains that are benign. And it may be related to microvascular dysfunction, but most of these patients can be treated conservatively. So I'll just finish there. I know I went probably over time, that SCAD is not rare. We need to think about SCAD in young to middle-aged women. We all need to be better at diagnosing SCAD on angiogram, and conservative treatment is still first-line treatment, but if you have to intervene for patient ongoing ischemia, go ahead with PCI, but just know the techniques. And most of these patients, if they survive the hospitalization, the long-term outcome is actually pretty reasonable. And we need to screen for FMD because that is the most important cause for SCAD and can also increase your risk of recurrent events. And I'll just finish there.
So thank you very much, Jackie. That was a fantastic lecture. This was the keynote lecture, so traditionally there are no questions, but we will have one question. And I don't know if someone from the audience, maybe Dr. Karagounis would like to have a question for you. I presume you are in Paris for EuroPCR, correct?
Yes, I am.
Well,
yeah.
thank you very much for
So Dr. Karagounis.
We appreciate very much your talk. I was wondering, those patients that they go to the cabins, if they have particular challenges for the surgeons. In other words, if the vessels are more susceptible to dissections and they need to apply special techniques to do the bypass.
Yeah, that's a very good point. I've spoken to our surgeons at length about this. And so our surgeons, if you have a normal segment, you can graft it beyond. So like if you have a type 2B dissection, you have a normal segment distal, they will graft distal. But if you don't have a normal segment, they would graft, they would have to separate, and it is friable. But even if you graft into some version of the false lumen area, you have perfusion through true lumen, you're actually still improving myocardial perfusion. So their preference is to graft beyond the dissection, but if you can't, you have to graft into the actual dissected segment. You do it, but you do it very cautiously.
Thank you very much, Jackie. We have one more question for you. How common do you think it's the underdiagnosis of SCAD in a regular, cath lab? Because you guys are experts. I mean, you look for it. Do you think that it's misdiagnosed and we miss some cases?
Oh yeah, we still miss a lot of the cases. Now, in more contemporary series, we're saying 4% of all ACS are SCAD. But even that, I think that number is still very low. So I would say that if you have a woman presenting and they're less than age 60, if you're not picking up 1/4 to 1/3 of these cases as being SCAD, you're definitely underdiagnosed in your lab.
To be honest, I would like to ask you something. I was very surprised that the CTCA was so low and had such a low sensitivity. What are your sort of key features? What are your key points when you look at the CTCA to say, here, that's a big suspicion, that's a SCAD?
Right. So one feature is, okay, you have otherwise normal vessel elsewhere, right? And then you see this, if you see a long kind of subtle narrowing, as one of our first CT that we did was this case on the left-hand panel that I showed, the first women who's like long diffuse RCA. We did the CT and we saw long minor narrowing, and our radiologist said, oh, maybe it's inflammation, maybe it's just inflammation. They didn't know it's intramural hematoma. So this long diffuse narrowing. But the thing is, you can miss that because a lot of these SCADs are not the large vessels. They're involving vessels that's less than 2.5 millimeters. So the resolution on a cardiac CTA, the voxel is 0.6. So it's not as good as the 0.1 resolution we have on coronary angiography. So you can still miss those ones. So I would say if you have a patient that you're worried about, SCAD generally, you would still need to do catheter angiography. But if you have a patient previously who had a SCAD diagnosis and now present with another, say, non-STEMI, and they're stable, and you just want to rule out a big vessel SCAD, then I can do a cardiac CTA. But you might miss the more distal segments of SCAD.
Okay. Any more questions? Yeah, Dr. Kapitanopoulos, that will be the last one.
Thank you for this wonderful lecture. I got a little confused though about the screening for FMD. You said CT has low sensitivity and digital invasive angiography has better sensitivity, but we still do CT. So what's the final recommendation for screening for FMD, and what do we do with this information after that?
Perfect. Yeah, that's a great question, because the FMD Society, FMDSA, recommend basically you do CT is the gold standard to pick up FMD nowadays, because it's uncommon to do invasive angiography. But for our SCAD patients, because they're in the cath lab, right? You already done a coronary angiography. Then I'll just do a pigtail, non-selective injection of the abdominal aorta, and then just above the iliac. Then you would actually see FMD from the catheter angiography, and then pick up that rate of the sensitivity to pick up FMD is a lot higher with that strategy than doing CT. But if the patient is, had a SCAD done in a different hospital, I'm not going to bring them to the cath lab just to do a catheter diagnosis of FMD. I would do a CT, which is why you're seeing such a variation in the prevalence of FMD in SCAD patients in the literature, where we're saying it's more like 60%, but if you do catheter angiography, you're going to pick up FMD in about 80% of cases in SCAD patients.
Thank you very much, Jackie. We're very happy that you gave us this lecture, and good night from Thessaloniki.